Numerous studies show increased prevalence of ocular surface dysfunction in patients who have diabetes, including higher rates of meibomian gland dysfunction, tear film instability, and neurotrophic keratopathy. And yet, in most EHRs, it doesn't show up as a coded diagnosis and rarely appears in follow-up plans outside of the annual comprehensive exam or annual diabetic eye exam, quote unquote. AI doesn't catch these. The fundus photo doesn't tell us who is suffering from fluctuating vision or ocular discomfort or early optic nerve changes. A comprehensive diabetic eye exam is not fundamentally different from a comprehensive eye exam. It includes all the same elements. A retinal evaluation to be sure, but it also includes refraction and accommodative testing and binocular vision and convergence and anterior segment and tear film and glaucoma risk and visual function and macular risk and counseling on systemic risk, etc., etc. And in all of these risks and ocular diseases, patients who have diabetes are at an elevated risk. Here's a patient example. A middle-aged man with type 2 diabetes comes in for his quote-unquote annual diabetic eye exam. Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today I wanted to talk about the diabetic eye exam, and really we get a lot of questions, and recently I've had a lot of questions related to this, and mostly it is about the fact that primary care doctors are fulfilling this requirement now using AI and fundus photography. And so I'm getting a lot of optometrists that are reaching out saying, how does this happen? And so I thought I'd reflect on that, probably the bigger and deeper problem, and maybe, think about how we've contributed to that problem. So please enjoy this monologue. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local MacuHealth representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to MacuHealth.com and use the coupon code PODCAST2024 at checkout for special discounts. Somewhere along the line, we let the diabetic eye exam become synonymous with the fundus exam. And from there, it wasn't a big leap for payers and systems to reduce that even further to a fundus photo. But here's the thing. That shift didn't come from policymakers alone. We helped shape it. As a profession, we overemphasize the fundus exam as the clinical anchor of diabetic eye care. And maybe we accepted it and embraced it because it placed us in the center of a healthcare quality metric for the last 20 years. We taught it, we talked about it, we billed for it, and sometimes even built practices around it. And when fundus photography became easier and more billable, we leaned into that too. Even when it was questionable whether or not it was medically necessary, we told the system what mattered, and the system listened. But it listened to the part that we repeated the most. So now here we are, watching AI interpret fundus images to fulfill HEDIS measures, and we're concerned about our value being replaced. But the real value isn't the rise of AI, and the real issue isn't that either. It's the narrow definition of the value we allow to take hold, the fundus evaluation. So let me give you a little bit of review. You all know this, but HEDIS measures, like the eye exam for patients with diabetes, require documentation of a retinal or dilated exam during the measurement year or the prior year. Especially allows for fundus photography and increasingly AI-interpreted fundus images to count. And oftentimes, that's even more prevalent in patients who are at low risk for vision loss from their diabetic retinopathy. And so this creates a system where the primary care doctors and health plans can check a box without involving an optometrist. It's efficient. It stratifies compliance, but it doesn't serve the patient. And we need to articulate how that's the case. What's worse is that in emphasizing the risk of blindness from diabetic retinopathy, which is valid, totally valid, we've contributed to this box-checking model. We've placed so much importance on the fundus exam that we made the entire exam in the eyes of the healthcare system. We've made that fundus exam the only important thing to the system. So think about it. How often have we billed for fundus photos in patients with no pathology, simply because the system would pay for it? How many practices market fundus imaging as a key feature of care? How many peer conversations reinforce that that is the metric of quality? And when we do this and only this, and we don't follow up with the patients with other risk factors and show through our billing processes and our follow-up processes that we're actually paying attention to other things, then all they see as a value for patients who have diabetes is fundus photography and evaluation one time a year. So don't get me wrong, fundus photos are useful, but they're not a replacement for a dilated exam. And the dilated exam is not a replacement for comprehensive eye care. And that's probably the most important point. Retinal imaging lacks, obviously, peripheral visibility, even with ultra-wide field imaging. It lacks depth perception, certainly. It lacks dynamic assessment and clinical context. But more importantly, it cannot evaluate IOP. It can't evaluate anterior segment pathology, binocular function, dry eye, cataracts, or early glaucoma. It can't do any of those things. And even more importantly, it doesn't examine the patient. It captures an image. It doesn't interpret systemic risk, visual needs, or lifestyle. It doesn't educate. It doesn't build continuity of care, and it certainly doesn't enhance the doctor-patient relationship. Take glaucoma, for example. In patients with diabetes, the risk of developing glaucoma is nearly twice that of the general population. But how many of our diabetic patients are receiving optic nerve OCTs, visual fields, and gonioscopy, not just IOP checks, not just fundus photography? How many of them have documented glaucoma risk level or a follow-up plan outside of that anterior or that comprehensive exam annually? Think about dry eye disease. Numerous studies show increased prevalence of ocular surface dysfunction in patients who have diabetes, including higher rates of meibomian gland dysfunction, tear film instability, and neurotrophic keratopathy. And yet in most EHRs, it doesn't show up as a coded diagnosis and rarely appears in follow-up plans outside of the annual comprehensive exam or annual diabetic eye exam, quote unquote. AI doesn't catch these. The fundus photo doesn't tell us who is suffering from fluctuating vision or ocular discomfort or early optic nerve changes. A comprehensive diabetic eye exam is not fundamentally different from a comprehensive eye exam. It includes all the same elements. A retinal evaluation to be sure, but it also includes refraction and accommodative testing and binocular vision and convergence and anterior segment and tear film and glaucoma risk and visual function and macular risk and counseling on systemic risk, etc., etc. And in all of these risks and ocular diseases, patients who have diabetes are at an elevated risk. Here's a patient example. A middle-aged man with type 2 diabetes comes in for his quote-unquote annual diabetic eye exam. No retinopathy is visible, but during that exam, he reports fluctuating near vision, mild diplopia when he gets tired. Binocular vision assessment shows some convergence insufficiency. He also shows reduced corneal sensitivity, irregular meibomian gland function, and none of this shows up on a fundus photo. And it won't show up if we don't purposely follow up with that patient over the course of that year to address those other problems, and we cram it into the comprehensive diabetes annual eye exam and code E11.9, bill for the photo. I'm not saying to do it or don't do it, but we do it.
CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today.
If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. That's all that shows up. But all those things impact his quality of life, and arguably, probably more importantly, impacts his quality of life than his general systemic diabetes, which is relatively well controlled. Maybe he's on a medication, oral medication, trying to help. And our care is what will actually help him improve function. We must also recognize our own role in perpetuating the fundus first model. And when we bill fundus photography routinely, even without retinopathy, we send a message. This is the part that matters, the fundus. And the system responds accordingly. If we want a different message to be heard, comprehensive care, we have to change what we emphasize. Most patients think their vision plans cover a diabetic eye exam, and what they don't realize, obviously, and we go through this all the time, is their medical plan often should be the payer. And the exam is the same, and the patient sees the exam as the same, no matter which card they present. The confusion traps providers in an ethical dilemma. Do I cram every possible service into one visit, even if the patient needs more, or do I push back and risk a coverage dispute or a patient dispute? Too often we default to minimizing friction, giving everything in one visit, and letting vision plans dictate the structure of our care. And I would argue, and I've have before, and I probably will again in the short term, that even if the medical payer pays for that, it doesn't remove the problem that service alone for most practices, based on the duration of the visit, do not generate enough revenue to support the practice on the care alone. They have to sell glasses in order to account for it, even when medical payers pay. But this leads to burnout, underdiagnosis, systemic underappreciation of our value, and it starts with a misunderstanding, both by the patient and by the provider, and that a diabetic eye exam is somehow a unique thing. It's not. It's a comprehensive eye exam applied to a patient with systemic disease and systemic risk, and that's it. That's enough. That's all it is. And if we want to change, we don't start with CMS or HEDIS. I mean, certainly we can articulate the problem with them, but we have to start in our own exam rooms. We have to start by remembering that a patient who has diabetes is a whole patient. They may or may not have retinopathy, but they absolutely have a higher risk of dry eye and glaucoma and cataracts and macular gland dysfunction and neurotrophic keratopathy and fluctuating refraction and fluctuating vision. They also need someone who reinforces systemic health messaging like lifestyle, medication adherence, coordination with the primary care doctor, and the retinal surgeons when needed. They need that message delivered more than once a year. We also need to change our internal narrative. We are not valuable because we detect retinopathy. We are valuable because we manage a patient who has vision. We manage complex chronic ocular diseases. We prevent blindness. We guide patients with systemic risks. That's our scope. That's our lane. So where do we start? Well, here's a challenge that I looked at for myself. So I went into my EHR, and I'm going to encourage you to do the same thing. Go to your EHR, audit your diabetic patient population. How many have had an optic nerve OCT? How many have had a visual field? How many have had gonioscopy? How many have had documented glaucoma risk or ocular surface disease that you're actually managing outside of the ocular surface or the comprehensive exam, the diabetic eye exam? How many have those diagnoses with a targeted treatment plan? And what percentage of them have follow-ups beyond that annual exam? Now compare that to your non-diabetic patient population. Are you managing the actual risks your patients have, or just the ones that are easy to check off? I know it's easy to do. I have to fight my own. I call it, for myself, I'll call it laziness. I have to fight my laziness every single day. I am inclined to be a lazy provider if I am not putting checks and balances in place. And so I would encourage you to start there. And if you need help, please reach out to us at Practice Performance Partners. We help optometrists mine their data and build real clinical workflows and redesign care models based on what patients need, not just what plans cover. Don't wait for the system to redefine our value. Define it yourself. Show your care, track your outcomes, and build something better. Build what you believe your patients deserve. I hope this was helpful. I'll see you guys on the next one.